Hi everyone, thanks for listening to my presentations. Today I want to start a series of 7 presentations on hypothyroidism, but I'll be starting with Hashimoto's thyroiditis, forming part 1 of 7 on hypothyroidism. Okay, let's go. Other names for Hashimoto's thyroiditis could be the way I've written it down as Hashimoto's thyroiditis or Hashimoto's disease, or chronic lymphocytic thyroiditis, or autoimmune thyroiditis, depending on the school of thought the author belongs to, or whoever has written a journal. You could find any of these 4 names, but whether Hashimoto's thyroiditis or disease or chronic lymphocytic thyroiditis or autoimmune thyroiditis, all about the same condition. The history of hypothyroidism is incomplete without that of Hashimoto's thyroiditis, and that is why the 7 presentations on hypothyroidism will begin with Hashimoto's thyroiditis as part 1 of 7. When it comes to Hashimoto's thyroiditis, more women are affected compared to men, and the ratio will be between 8 to 1 respectively. Hashimoto's is the common cause of hypothyroidism in the Western world or in iodine-sufficient advanced countries. Hashimoto's thyroiditis could have any of the following characteristics. It's either having gradual loss of thyroid function, and Hashimoto's thyroiditis could have the problem with goiter, or could be Hashimoto's thyroiditis without goiter. There is possibility of apoptosis of thyroid epithelial cells and is closely related to Graves' disease, or one can actually evolve to the other. Hashimoto's will have many phenotypical presentation. It can also be with hypothyroidism or without hypothyroidism. That is Hashimoto's thyroiditis. So the fact that this individual has been diagnosed with Hashimoto's thyroiditis doesn't make it clear-cut definition of hypothyroidism. Sometimes may be without hypothyroidism or could just be with subclinical hypothyroidism. So you might see goiter either peak by ultrasound or visible, big enough to be seen visible, or without goiter with atrophic thyroid gland. So it could be with goiter, but when the thyroid gland has atrophied, then it will be without goiter. Okay? Serum thyroid autoantibody will be the proof here. So we'll see, could be this, could be that, but what's your proof? Serum thyroid autoantibodies will be the proof. Risk factors. Genetic susceptibility is very strong. Stress has been identified in some as the risk factor in Hashimoto's thyroiditis. Pregnancy, fetal micromerism, that is, 2 genetically distinct cell populations in the same individual, could be the underlying risk factor here. Iodine intake, either increased iodine that might probably lead to increased Hashimoto's. Sex steroids, drugs, radiation, gender, more in women, viral infections, another autoimmune disease. Let me now explain further here. When you diagnose an autoimmune condition in any patient, then you better be on the lookout. There is that possibility of another autoimmune condition, like if there is systemic lupus erythematosus, rheumatoid arthritis, or Sjogren's syndrome, or sarcoidosis, or pernicious anemia, given megaloblastic anemia, then Hashimoto's should be ruled out as well. Then it could occur at any age, but more in women. Mechanism as molecular mimicry, bystander activation, and thyroid cell HLA expression. Hashimoto's, like I've shortened it to be Hashi because I've been talking about it now for a long period of time while going through this presentation. So permit me to just shorten into Hashi. Hashi is also known as chronic lymphocytic thyroiditis, often leading to a trophic gland and hypothyroidism. Of course, what are we talking about? The gland has suffered enough. The gland is now reduced to a small size. That is why it could be without goiter. And of course, when the gland is already reduced to a smaller size, where would the hormones be coming from? We'll be talking about T4, T3, recombinant T3 later on. Where will it come from? That's where we have hypothyroidism. Mostly affecting middle-aged women, but can also occur in men and women of any age, and even in children. Clinical features. The clinical features will be mostly clinical features of hypothyroidism, and that will form the part 2 of 7 of this series. So, I'm indirectly telling you that after you've gotten this very presentation, which you are doing right now, you are going to see the presentation on clinical features of hypothyroidism the next 2 days. Just check my channel, okay? Then, there you are going to find all the clinical features of hypothyroidism, which is supposed to be here, but I want to make it a fully elaborate, detailed presentation, okay? So because I'll be talking about the effects of hypothyroidism when it comes to central nervous system, gastrointestinal tract, cardiovascular, respiratory, musculoskeletal, reproductive, adrenal, hematological, and so on. Okay, check my channel, you'll find them. Number 2, goiter. Like I've explained before now, Hashimoto's could present with goiter or without goiter. Without goiter, when the thyroid gland has been massively destroyed and the goiter has reduced to, just a tiny structure. So where are you going to see the goiter? No more. The goiter will disappear, okay? It will be painless. And we might be dealing with subclinical hypothyroidism that will later progress to overt hypothyroidism. Like I've said, that with increasing destruction of the thyroid gland will shrink, and that will lead to disappearance of the goiter. Diagnosis. How to make correct diagnosis of Hashimoto's thyroiditis? Okay, let's go. Thorough history, physical examination, ultrasound of the anterior neck, right? Then we'll assay the thyroid peroxidase antibodies. That is going to be the proof, right? Then thyroid stimulating hormone from the pituitary gland, right? Then thyrotropin releasing hormone from the hypothalamus, right? T4, T3 from the thyroid gland itself, complete blood count, glucose, microscopy, culture and sensitivity test, renal function test. We're not done yet. Liver function test, antinuclear antibody. Someone is asking me, what's the problem with antinuclear antibody, rheumatoid factor, C-reactive protein, or erythrocyte segmentation rate? You know what I'm reading out, right? Autoimmune conditions, right? Now, even I can carry out some other, specific tests to rule out specific autoimmune condition like megaloblastic anemia, pointing to pernicious anemia. This is an autoimmune situation, right? So just want to rule out so that you'll be sure you are dealing with Hashimoto thyroiditis alone, because if you have concomitant autoimmune conditions, you might be dealing with symptoms that will not be amenable to your treatment. Treatment. The treatment will last for a long period of time, usually between 3 and 6 months. But it's not everybody that will be treated. If this patient is asymptomatic, then why jabbing the individual with a lot of medications? Do nothing, but keep monitoring. Okay? If this person is having features of hypothyroidism, one medication, that is levothyroxine. Nowadays, some authorities will combine levothyroxine with T3, that is T4 with T3. Some argue that no special advantage, some argue that that's good enough. Discuss with endocrinologists in your jurisdiction. And of course, remember the protocol at your center. If we are dealing with Hashimoto's encephalopathy, as a matter of fact, I will have a separate presentation on Hashimoto's encephalopathy, okay? And that will form part 7 of this series. They will be the very last one, okay? Check my channel in the next 2 weeks for that. We have to repeat thyroid function test every 8 weeks. Then, when we are having a comfortable region, the results are pointing to bearable values that are within the normal range, we extend the period of time for testing. So from every 8 weeks to every 6 months. Warning: avoid iodine or soya-rich diet while taking T4, levothyroxine. Remember, it's given per order, right? And if you want to ask me why, check my channel. There is a separate presentation on relationship between soya milk, soya diet, and T4. Just check my channel for that. Complications. Increased mesenchymal coma is possible with Hashimoto's thyroiditis, cardiomyopathy, and of course we know everything associated with cardiomyopathy like arrhythmia and heart failure. Hyperlipidemia, particularly with hypothyroidism. Depression with hypothyroidism. Increased ischemic heart disease. And of course, still on complications when it comes to pregnancy, hypothyroidism in pregnancy is due to Hashimoto thyroiditis until otherwise proven. Okay? Hashi is the commonest cause of hypothyroidism in pregnancy. And if a pregnant woman is diagnosed with Hashimoto thyroiditis or hypothyroidism, it can lead to miscarriage, premature birth, stillbirth, preeclampsia, poor growth, and of course, impaired brain development. With that, I've come to the end of this very presentation. The next presentation will be on hypothyroidism symptoms. That will form part 2 of 7. That will be published in the next 48 hours. You can check my channel for that. Thanks for listening. Please remember to share and subscribe. I appreciate it.